Today I'll talk about role of postoperative adjuvant treatment for advanced gallbladder cancer. This is our country Korea data, incidence, mortality, and survival rate. Gallbladder cancer and biliary tract cancer all together, and maybe there is about 2,000 cases per year, and survival rate is slightly increasing in survival rate to 27%, but still dismal. Today I'll talk about outcomes, challenges, pattern of disease recurrence, benefits of adjuvant treatment, and summary. This is survival data in SEER USA data, more than 10,000 cases. There were significant differences in survival between the groups according to the stage. This is just Japan nationwide study, more than 3,000 resected patients. Also, there were significant differences between groups according to stage. This is our hospital data, and stage 2 resective stage 2 patients only 40% of 5-year survival rate. And in this paper, we analyzed prognostic factors, and adjuvant therapy shows no negative result. There are many challenges which face clinical trials. It's rare disease, little interest, little phase 3 trial, little randomized controlled trial. And it's heterogeneous group, biliary tract cancer, extrahepatic cholangiocarcinoma, intrahepatic cholangiocarcinoma, even ampulopathal cancer patients are included. And it's limited effective, there was limited effective chemotherapeutic agents, and complex surgical procedures, and high morbidity and mortality. And also there are many compounding factors: histology, tumor burden, growth pattern, type of surgery. And all here doctors know the importance of obstructive jaundice and cholangitis, and rapid clinical progression with limited life expectancy. This is Memorial Sloan Kettering data, pattern of disease recurrence. In gallbladder cancer, almost 85% has distant metastasis, compared with 40% of hilar cholangiocarcinoma. Distant metastasis is predominant in gallbladder cancer recurrence. This is our hospital data, and time to recurrence is 6.3 months in gallbladder cancer, compared with 13.1 months compared to extrahepatic cholangiocarcinoma. This is also our hospital data. Pattern of recurrence is distant pattern metastasis is 70% in gallbladder cancer. So these data highlight the importance of chemotherapy rather than radiation therapy in gallbladder cancer adjuvant treatment. I'll talk about benefits of adjuvant treatment. This is B slide, but adjuvant chemotherapy data. All studies are phase 2 study. Only one this study is randomized controlled trial. Although retrospective series have suggested some degree of benefit from adjuvant chemotherapy, but data are limited and selection bias is included. This is Chile data, and this is Korea data. And this is biliary tract cancer chemotherapy meta-analysis paper. It's a palliative setting, not adjuvant setting, and all includes biliary tract carcinoma altogether. And more than 100 trials and about 3,000 patients, but only one phase 3 trial. In this paper, response rate is 22%, and overall survival 8.2 months. There was significant but weak correlation between response rate and overall survival. When increase of 10% increase of response rate, 0.6 months increase of overall survival. Combination chemotherapy resulted much more increase response rate. And among these regimens, you can see in this picture, gemcitabine plus cisplatin combination has highest response rate and tumor control rate. This is landmark study published in NEJM 2010. This is also biliary tract cancer altogether and palliative setting. In this phase 3 randomized control trial, cisplatin low dose and gemcitabine combination every 3 weeks, the overall survival increased 11 to 7 months. And in gallbladder cancer, positive result, but complete response is 0%, partial response 37%, stable disease 47%, and tumor control 52%. And this is palliative setting also. I will talk about adjuvant chemotherapy. This is a previous mentioned Japan nationwide study, and chemotherapy result, negative results, even worse than no chemotherapy. Only positive result in stage 4A cancer patients. This is previous mentioned only one randomized control trial from Japan. Positive results only in gallbladder cancer for mitomycin C plus 5-FU, but only positive result in non-curative setting, not curative setting, and 26% and 14%. But small limited number, and 90% has no lymph node metastasis. So data regarding the extent of surgical resection and histologic staging were lacking, making the results difficult to interpret. This is also busy slide. Recent studies of adjuvant radiotherapy, but all studies are a retrospective phase 2 study and no randomized control trial. This slide, but positive result for red color and negative result for blue color. You can see surgery, adequate surgery is important for prognosis. All retrospective data, so missing and inaccurately reported data, and also there could be selection bias, possibility of selection of better performance patients for adjuvant treatment. Also small number, inadequate other cancer are limitations, making it difficult to draw meaningful conclusions. This is our hospital data, and positive result for only disease-free survival in lymph node metastasis, but not overall survival. This is recently published meta-analysis. 6 studies, 1 randomized control trial, and 5 phase 2 studies, usually external beam RT. Also selection bias, stage and resection margin lymph node data are missing, and evidence level is not so high. The results, p-value is not significant for gallbladder cancer. In the subgroup analysis, resection margin has significant positive results, but there's only 3 studies. And for lymph node positive, negative result, p-value is marginally negative. This is ongoing adjuvant studies. There are phase 3, 2 phase studies, capacitive versus observation, GMOX versus observation, but all include other biliary tract cancer. And this is my study in 2010, started from 2010, also included other cancer, 72 cases, recurrence free at 2 years with gemcitabine single monotherapy. And our study, gemcitabine every 4 weeks for 6 months. And this is preliminary results. 2-year recurrence-free survival 42%. We have almost done, and only few patients left. This is adjuvant setting, not a palliative setting. So patient safety is very, very important. We experienced 2 gemcitabine associated pneumonitis, and this patient survived with the steroid trial, but these patients died instead of intensive care therapy. So we analyze now pathways of gemcitabine transport metabolism and site of action, and we analyze correlation of cytidine deaminase, but data are preliminary. And this is NCCN guideline for gallbladder cancer. Consider fluoropyrimidine, chemoradiation except T1 and 0, or fluoropyrimidine or gemcitabine-based chemotherapy. This is NCCN guideline. In summary, do patients gain any benefit from adjuvant treatment? But there is a lack of well-designed randomized controlled trial, inconclusive and underpowered. And importance of performing adequate surgery is very important, and adjuvant therapy does not mean compensate inadequate surgery. Chemotherapy might be a more rational adjuvant treatment strategy than RT alone. Optimal regimen and period has not been established. We have impressions of survival advantage, especially more than T2 stage, lymph node positive, resection margin positive, because of these patients has poorer prognosis. But does high risk status mean benefit from adjuvant treatment? We don't know yet. Gemcitabine or fluoropyrimidine based chemotherapy or fluoropyrimidine chemoradiation except T1 and 0. This is consensus based guideline. Last slide. Future clinical trial, largely prospective randomized control study is needed, and surrogate marker and molecular markers and development of novel agents are needed. Thank you for your attention.